Good evening, everybody. This is Dr. Kurt Woeller checking in. I appreciate you joining me tonight for another webinar hosted by Great Plains Lab. This particular webinar is, I think you'll find, quite informative. Titled Autism Spectrum Disorders, the link between behavioral issues and often overlooked digestive system problems. This is actually a modified lecture that I did within this past year for a group of physicians who weren't really familiar with autism, but it was my opportunity to introduce them to the complexities that we see medically with kids on the spectrum, and the presentation actually went over quite well. This is a modified version. I took some things out with respects to defining autism and statistics, etc., which most everybody here knows. So the meat of this presentation is really just getting right into many of the gut problems that we see, and I think you'll find it helpful. As a heads up, before I get started, I'm going to be involved in some one-day intensive seminars. If you are a healthcare practitioner, that is an MD, a DO, a naturopath, a chiropractor, acupuncturist, nutritionist, then I would encourage you to join us at one of these locations. Starting in October, we'll be in Seattle, in December, Houston, Texas, and then in February in San Diego. The point of these one-day intensives is to really go over the organic acids test with respects to how to implement it in your practice. And this is not just for autism. This particular one-day seminar is, can be applied to many other types of chronic health conditions. So hopefully you can join us at one of those locations. For more information, you can go to greatplainslaboratory.com. So tonight we're going to get right into the issues with respects to autism. I'm going to go through some case presentations, some of the common GI problems seen in autism, and then we'll build some cases around that. You'll see some slides here on inflammatory bowel. And then the tail end of the presentation is going to get into some of the science with respects to gut bugs, the neurochemical influence that these gut infections can have, and then we'll wrap a case up with respects to Clostridia-induced behavior problems seen with many kids on the autism spectrum. So we know that there are many faces to autism, that not all kids are the same, and that there are certainly many degrees of severity with children on the autism spectrum, and that could be the same with teenagers and adults as well. And so, the reality is that autism, as you know as parents, and if your practitioners listen to this, it really is a very individualized disorder. And so we don't always have the same presentation, although most of the kids on the spectrum, or teenagers or adults, have very similar things going on. The problem is that there really is a scary reality for families with autism in some kids who have extreme behavioral problems, and particularly the self-injurious and aggressive behavior. One of the things I pointed out to this physician group was that they, as medical practitioners, you really need to try and avoid moving in the future here, if they start working with this population of people, is to not be lulled into that the diagnosis is the only defining issue that this child is dealing with. And what I meant by that is there is a tremendous amount of comorbid conditions, digestive problems, allergies, chronic infections, immune disorders, etc. And that not to become blinded by the diagnosis and think that these other comorbid problems are to be ignored, because that ultimately is what's happening, is that the vast majority of kids on the spectrum who are dealing with behavioral issues, no one ever looks at any kind of testing. No one ever looks to try to put the pieces together to figure out why those behavioral problems may be occurring. And that's what this presentation was about for them. Now, we know that self-injurious behavior can be associated with sensory system imbalances. Matter of fact, these were two research studies that were done some time ago that looked at just that, looking at sensory system imbalances with kids on the spectrum related to aggressive behavior and self-injurious behavior. And even in kids with autism and Fragile X who had brain volume changes that were detected through imaging studies that showed that certain areas of the brain were affected that are known to lead to aggressive and self-injurious behavior. So there can be some neuroanatomical explanation for some kids on the spectrum, but not all. Well, as a follow-up discussion to that, we know that seizure disorders are quite prevalent in the spectrum community. And as a matter of fact, it's upwards of 30 to 40% approximately now that is suspicious that kids on the spectrum have some type of seizure problem. And it certainly is known that seizures can be a cause for aggressive and self-injurious behavior. So there certainly can be, again, neuroanatomical imbalances that can contribute to the problem. Well, I've had a number of cases over the years with kids in my practice who've had very, very severe aggressive behavioral problems, self-injurious behaviors. And this particular individual, which I call case 1, is probably one of the most difficult and severe cases that I've ever seen. And these are just some images here of severe headbanging that this child would do when they were in a stage of rage and, causing huge lacerations on the scalp. Very, very severe and very, very troublesome. In fact, the parents actually had to pad the room because the child could be so self-injurious. So there's many cases like this. Not every child I've seen is like this. Perhaps if you're a parent out there, I hope that you're not dealing with this. But let's explore what may be some other reasons why this may be going on. So what are some of the common GI issues in autism? Well, just like everyone else, kids on the spectrum, and when I say kids on the spectrum, I really sort of encompass everybody, kids, teenagers, adults. It's because my practice is so much centered on working with parents with young children. So, they deal with many of the same common intestinal problems that anybody would. So stomach inflammation, reflux, colitis, irritable bowel, constipation, motility-based disorders. That basically means that the bowels are not functioning properly. They're not moving food and moving stool through the bowel adequately. And then, of course, there's a lot of evidence that food allergy and sensitivity and overgrowth syndromes, which we'll talk at the end, which are the bacterial and yeast issues, are quite a problem. And there's been a lot of research over the years, and I just kind of highlighted a few things here. Now, this particular article came out in 2006, and what they were doing is they were evaluating children on the autism spectrum and then 2 control match groups for same age, sex, and ethnicity. One who had a non-autism developmental disorder and another group who was developmentally normal. And there were 50 kids in each group. And what they found is that 28% of the children with neurotypical development had some GI-related issues: bloating, gas, constipation, loose stool, abdominal pain. Turned out that 70% of the children with autism had GI issues compared to only 42% of children with the developmental disorder, but they were not autistic. So huge number of kids on the spectrum, more than the neurotypical kids, had GI-related issues. Another study in 2013 found very similar results, that the gastrointestinal problems in autism were quite prevalent compared to typical development or neurotypical children of the same age and sex. And so they were just sort of correlating what that other study showed. And what we have really seen over the years in our practices, that a significant amount of kids on the autism spectrum have GI-related issues. Again, abdominal pain, gas, loose stools, constipation, etc. So let's talk about constipation for a moment. And really, there's sort of 3 different scenarios surrounding constipation, or at least I could say this in this particular case, 3 different cases that I want to highlight. Because constipation is a big problem, and it can be a big trigger for behavioral issues, and it's often overlooked, and it's not well appreciated and not well recognized, particularly by the medical community. So this particular case was a 5-year-old boy. The age of autism diagnosis was 2.5. The main issues were very typical, fairly typical expressive language, social withdrawal and avoidance, a lot of sound sensitivity. The child was non-aggressive or self-injurious. So this is one of those cases where we were not looking at a severe behavioral issue, but there was some troubling behavior that the parent was bothered by. This was a repetitive behavior where the child would lay flat on the floor and rub back and forth. On physical examination, had a quite distended abdomen, kind of that pregnant belly look. And so we did some inquiry into, what was the stool pattern like, and what was his bowel movements like, and the parent reported that, he had normal bowel movement every day, but he had a lot of foul-smelling gas. That is very common of anybody who is constipated, usually a lot of foul-smelling gas, and certainly there can be a bacterial imbalance occurring as well. Well, sure enough, on x-ray examination, this particular child was just packed with stool. And there was no intestinal obstruction or, anything that was noticed in that respect, but they just had a lot of poop in the belly. And I've often commented that many people, or many kids, when they have a bowel movement, sometimes they'll have a fairly large bowel movement. And the parent will think, well, my child moves their bowel every day. But what they don't realize is that that bowel movement was just a piece of a larger bolus of stool that's still in the digestive system. So all they're basically doing is pinching off a section. Case number 3, excuse me, was a 12-year-old individual. Age of autism diagnosis was around 3 years of age, and then essentially that was switched over to having a diagnosis of Asperger's. This particular child could have a conversation, socially awkward, like we see a lot with some of the Asperger's kids and individuals, and particularly with that lack of personal space boundaries. Behaviorally could become easily stressed and frustrated, would chew on his shirt, a lot of high anxiety issues, particularly at school, and what was interesting, particularly associated with bathroom use. The main concerning behavior of the parents was that he would become obsessive and combative really emotionally when he would complain of stomach hurting. And that's another trigger. If you have a child that's complaining a lot of stomach discomfort, think constipation, because that constipation, the back pressure in the bowel, putting pressure up through the diaphragm can cause discomfort in the upper intestines. He'd often report that his stomach would hurt a lot after eating and throughout the day. And one of the interesting things is the parents noticed that when he was on the toilet, he would bend forward to have a bowel movement and could spend upwards of a half hour to 45 minutes in order to move his stools. Pediatrician had checked for Helicobacter pylori, bacterial infection in the stomach that can lead to reflux. He was given reflux medication, wasn't helpful. Tried some magnesium oxide. Magnesium oxide is a type of magnesium that can help with constipation because it's not well absorbed, so it has a laxative effect. Seemed to help a little bit, maybe slightly, but not a huge relief. Parents tried some suppositories when he was younger, seemed to cause some relief, but nothing really was consistent. And then eventually they saw a pediatric gastroenterologist who examined the child and found out he had something called rectal prolapse. And this was basically where the rectum was protruding from the anus, and there was a lot of laxicity down in the lower bowel. And they implemented some therapy with some magnesium citrate and Miralax, increasing fiber to create some bulk to the stool, and something called VSL3, which is a high-potency probiotic. So many times, the kid needs to be examined and have somebody can take a look at the rectum area to see if there is a physical problem down there. Case number 4 was an individual I had seen many, many years ago, but it really was an interesting case with respects to the behavioral problems. 14-year-old individual, age 2.5, at the autism diagnosis, and really was severely autistic. Main issues were nonverbal, poor socialization, a lot of anxiety, a lot of sensory-seeking behavior, and aggression. The main reason for the consult is the parent was just didn't know what to do with respects to the aggressive behavior and the destructive tantrums that this boy would partake in. The main physical challenge was that he was also severely constipated. He literally would not have a bowel movement for 5 to 6 days. The parent had tried some Dulcolax suppositories, did some Miralax by the pediatrician, major abdominal distension, nothing was really working. So we implemented an intervention to just try to, if you will, sort of shortcut or just typically clear them out, with respects to some of the built-up stool. And that basically meant, we're doing a Fleet's enema, 2 hours prior to Miralax dosing, and then using cyclical doses of Miralax, every half hour or so for a period of time. We're doing that every day to just try to really flush this kid out. And then after, to see if we could put him on a maintenance dose of Miralax over time. And then the parents started to introduce some things like, ground flaxseed and slippery elm herb, which is known to kind of help make the poop more slippery, and magnesium. Well, shortly after doing these enemas and Miralax, this particular individual had this was one picture, a huge amount of stool come out. Hard, compact, means it's been in there a long time. This is actually a police flashlight. These are big flashlights to show you how big this stool was. And this was just one that came out over a number of days. So he had major dump of stool based on the Miralax and Dulcolax suppositories. The mom reported that within 4 days of his bowel evacuation, his aggressive tantrums diminished about 75%. She also reported great progress. He seemed happier, more calm, less agitated, sleeping better. He could still be aggressive at times, but it was really around more when he was being reprimanded for negative behavior. But just a big, big difference in just getting that poop out. So I started inquiring a little bit further about his aggressive behavior patterns. Because I thought, okay, he's aggressive, he's got some behavioral issues, but it's not just constipation. It doesn't seem that it's just biomedical issues. So that was what really sort of kind of highlighted for me that it's not always a biomedical problem. It's not always the diet or lack of supplements or candida or Clostridia. There could be other things going on. So I inquired a little bit further. And the mom had mentioned that this particular boy would only hit her, his sister, his aunt, and this is what caught me, in the past, grandma. And I asked, well, what about his brother, father, grandfather, any male figures in his family? And nope, he would not hit any males. And so I asked, well, what happened with grandma? And the mom reported to me that grandma eventually got tired of being hit, and one day sort of slapped him back and stated right in his face, don't ever hit me again, to kind of an assertive position herself. And the end result was that grandma was never hit again. And so I had a discussion with the mom that this was not biomedical. This was a behavior that had been learned, that he has somehow learned that it's okay to hit women, which is not okay, and that needs to be rectified somehow behaviorally. Grandma took it upon herself to put her foot down, and so he no longer touches her, but unfortunately he still could be aggressive to other females in his life, and he already knew that he didn't venture into the males in his life to do this. So I've seen this pattern somewhat. It's not something that comes up quite commonly. I have seen it in a few other cases where the aggressive child will only hit the mom or only hit females in their life, and it's something that really needs to be dealt with from a behavioral standpoint. Well, case 5 is interesting from a different way with respects to aggression and self-injurious behavior. This particular case was really centered around aggression and self-injurious behavior, often associated with eating. 7-year-old boy I had consulted with. He was a twin born via C-section. Age of diagnosis was 2 years. Most of his spectrum issues was lack of expressive language, poor social interaction and interest, self-stimulatory behavior, kind of that typical finger flicking, finger hand twisting motions. Prior medical issues, though, were kind of interesting. About the age of 1 year, a lot of projectile vomiting episodes, and they suspected reflux early on, which was certainly a good suspicion. He generally always had some feeding issues, generally fussy and for the most part a picky eater. The main significant behavioral problem that was most concerning really began around the spring of 2013, where the child became very self-injurious, head banging, biting hands, aggression, particularly around mealtime. And what was interesting was that this aggression occurred shortly after a move from Texas to Kentucky. Started to have a lot of allergy symptoms, itchy eyes, runny nose, sneezing, placed on Zyrtec and some things just to try to deal with the allergies. Some relief of allergies, but his behavioral issues still occurred with meals. Finally, they got a referral, again, to a pediatric GI specialist who had a suspicion that there may be something more insidious going on in the stomach and the esophagus, and decided to do an endoscopy. And what they discovered was he had a lot of inflammation in the esophagus, and eventually diagnosed him with something called eosinophilic esophagitis. And this is where eosinophils, part of the immune system, infiltrate the lining of the esophagus, and they can infiltrate the lining of the stomach too, and cause a lot of inflammation and irritation. And this is exactly what they found, where it says here, sections of the esophageal squamous mucosa show a scanty interepithelial eosinophilic infiltrate. So basically what that's saying is the eosinophils are infiltrating the epithelial lining, the tissue lining of the esophagus, the feeding tube, and that causes inflammation. And you can imagine if the esophagus is inflamed, anytime you put food down there, it's going to hurt. So he was placed on some medication to deal with the inflammation. They were on a restricted diet, and he did quite well. As a matter of fact, a follow-up study to that showed that the inflammation and the issues had resolved quite nicely. So, and what they found clinically, as the parents reported, was behaviorally his improvement was remarkable. Within 2 weeks of the initial therapy, his self-injurious and aggressive behavior diminished almost upwards of about 80%. And within a month, there were no more issues. And really, for the first time, he had typical eating behaviors. So that's something to keep in the back of your mind. If you've got a patient you're dealing with who just has these ongoing food issues, maybe something more going on in the stomach and the esophagus that needs to be looked at. If it's a parent where you're just not getting good resolution with dietary intervention, there's still a lot of behaviors around eating, again, maybe looking at this as certainly a potential. Well, there are certain cases of kids on the spectrum who have more than just eosinophilic esophagitis or constipation or food sensitivities. They've got true inflammatory bowel problems. And for years, we've seen many kids go years without being diagnosed and ignored for the most part. These particular slides are from a greater presentation from a Dr. Arthur Krigsman, a pediatric gastroenterologist that I've worked with for many years. This particular website is a PDF which goes through in-depth many of the images that you'll see here. You can find that at callous-disregard.com. I'd encourage you to go there and take a look at this more in depth. And then there's just a research article based on some of the information you see here with what's called intestinal lymphocyte populations in children with regressive autism, looking at the bowel mucosa with respects to inflammation and irritation from an abnormal immune system. So we know that the esophagus, just like we talked in the last case, can be infiltrated with eosinophils, and that can lead to reflux, inflammation, and pain, and lead to that irritability with eating. And some kids show up to have polyps, and Some even have ulcers, ulcerations in the stomach, ulcerations in the duodenum, the upper part of the small intestine. Think about this if this was occurring, what it must feel like eating food or how that might affect behaviors. Dr. Krigsman has also documented severe cases of reflux. And in this particular image here, we have bile, okay, bile that is in the bowel, refluxing into the esophagus. And in these particular cases, kids having a tremendous amount of pain. Remember, the kids can't talk, they can't tell you how they feel, so they may be avoiding food. They could be pounding on their chest, holding their stomach, tantruming, whatever it may be. But this is going to be painful and certainly not comfortable. There have been cases of not only reflux of bile, but stool into the stomach. These are severe cases of intestinal motility problems, and that's often what leads to the extended bowels. Matter of fact, distension type seen in autism is that lower the lower bowel where it looks like a child is pregnant, where they're holding a lot of gas and stool in the large intestine. And if you've got that distension pattern where it's really protruding from the bottom of the rib cage or the bottom of the sternum, you could be looking at a situation of either food stuck in the stomach or just food or stool way back and back pressure of gas way back up into the small intestine as well. What is often done from a gastroenterology evaluation is doing a scoping procedure, looking down the throat, looking at the esophagus, looking at the stomach, looking at the upper intestine for inflammation or signs of disease. In some cases, they've got to do a pill cam. And this pill cam is where this is basically delivered into the upper part of the intestine, and this camera is then moves through the bowel and takes images that is sending an image to a belt that a child is wearing that has a receiver on it, and then they can look at the images later. And what happens with many kids is they show up to have very high immunological activity in the part of the small intestine called the ileum, which is the last part of the small intestine. But it's also the most highly immunological area of the digestive system. Signs and symptoms of ileum inflammation, you know, from diarrhea to constipation to self-injurious behavior to food avoidance, you name it. So this is something that needs to be appreciated and recognized, that if we're not seeing good resolution with a child from a dietary standpoint, if they have recurrent bowel problems, recurrent yeast and bacterial issues, recurrent stool issues, on top of behavioral problems, top of overall health issues, you most likely are dealing with some type of chronic bowel inflammatory disease condition. At least that's been my experience. And some of the kids actually have large bowel inflammation. Here's ulcerations in the large bowel, inflammatory polyp in the large bowel. That is true inflammatory bowel disease. The other thing to consider is what does your child's stool look like? And as I mentioned to these docs, what does your patient's stool look like? This is not normal, particularly if this is normally the way it is. Occasional loose stools are a normal part of our existence. You could eat, you could eat something that your body just didn't respond to really well, and you might get a day of some loose stools. But if it's constant, it's pathological, and this is something that needs to be recognized as not a normal pattern. The other thing to consider is the posturing. I often ask parents, does your child posture over furniture? Now, you might have a child who has a sensory pressure. They like pressure, for example, and so they'll run back and forth and push themselves up against the wall or the edge of a couch or against the floor. That's a little bit different. The kids that tend to leverage themselves like this over the furniture, the edge of a chair, the edge of a couch, many of them are trying to get a relief point of pain or discomfort in the abdomen. And particularly small kids who don't have the upper body strength to leverage it themselves, they've got to leverage their body over something solid. And this certainly can be a sign of intestinal pain. Also, self-injurious behavior is directly associated with inflammatory bowel disease, as Dr. Krigsman talks about in the research articles that I had highlighted previous to this particular section. So that brings us back to case 1. The first case I introduced, where we saw the walls that were bashed in by that child and the lacerations on their head. Let's go through this a little bit, and this will sort of help solidify some of the information I just presented with respect to inflammatory bowel. Essentially, this particular boy had a non-complicated delivery, hit his physical milestones normally, a little colicky as a baby, few ear infections, pretty typical. It did have a tendency towards constipation by about the age of 1, and it did seem to have some expressive language delay, but receptively his language appeared typical. By about 1.5 years, he lacked typical social bonding and really started to prefer to be alone. By age 2, expressive language was not progressing, and he was starting to show signs of anxiety. At 2.5, they were suspecting autism as a likely diagnosis. He began to develop more and more ear and respiratory infections and needed, some antibiotics, at that time to kind of deal with the situation. By about age 4, his bowels began to alternate between loose and constipation, started to become more rigid in his behavior, and that primarily meant that he was becoming more anxious. By age 5, the anxiety was really intense. He was treated with some Ativan and given Risperidol. Developed what was suspected to be something called tardive dyskinesia from the Risperidol. Hard to confirm 100%, but the Risperidol was stopped. Age 5.5, suspected absence seizures. He was treated with Trileptal, which did seem to help with some expressive language. Age 6 is when things started to get kind of strange. He had a treatment course of antibiotics for strep infection, and he began to manifest with even a greater heightened anxiety and new obsessive compulsive behaviors. Also started developing these guttural throat sounds. And so he went through a whole list of medications, Risperidol, Ativan, Zyprexa, Zoloft, all marginally helpful. About age 7, had blood testing that revealed low immunoglobulins. He was immunoglobulin deficient. And he also had a high ASO titer. ASO is linked specifically to strep. And so they suspected something called PANDAS. PANDAS is an autoimmune disorder secondary to strep infections that leads to obsessive compulsive and anxiety. Multiple treatment courses of Zithromax seemed to help the throat sounds and repetitive behavior, and overall he appeared just more calm with antibiotics. He also got something called intravenous immunoglobulin therapy for about 6 months, did seem to help with the OCD behavior, and then eventually those throat noises were also resolved. And then it was sort of a back and forth type of picture. Between 8 to 12 years of age, back and forth with Zithromax, anti-anxiety medications, behavioral therapy, speech therapy, pretty typical things to try to help him out. The overall presentation at this point was that he was improved. He wasn't exhibiting any aggressive or self-injurious behavior. He was still autistic, but he wasn't a behavioral issue. He didn't have behavioral issues of any significant degree. In the March of 2012, he developed what was sort of listed as a stomach virus. 4 days of nausea, high fever, vomiting, was overall lethargic, and for the most part in bed most of the time. On day 5, he got up from bed and literally ran into the wall, as the mom had described, and began to excessively headbang and have violent aggression. Shortly thereafter, he started with abdominal posturing over furniture, which I had shown you previously, and he started to have worsening stool patterns. They just became more and more loose. Now, it wasn't as though his gut was perfect all the time in the past. I mean, matter of fact, Mom had mentioned that it really never appeared normal, but it just got significantly worse. He was eventually admitted to the ER within a few weeks, and they kept him in sedation because of such severe, aggressive, and self-injurious behavior. Laboratory testing didn't reveal much. and they couldn't find acute infection. He was eventually discharged for follow-up with a psychiatrist. The psychiatrist was not convinced that he had a tardive dyskinesia reaction to risperidol and put him back on it. And it did seem to help calm him down, but he could still have a lot of volatility, still a lot of anxiety, and he continued to have bowel problems in the furniture posturing abdominally. So they started working with an integrative medicine doc down in the California area who diagnosed with a wide variety of environmental and food allergies. But again, he still had a lot of persistent bowel problems. Went back to the GP for a gastroenterology referral, but the GI doc refused to do a scoping procedure just after physically examining him. So that's when I came on the scene, because behaviors became worse and worse and worse. And I thought, this is a kid that minimally needs to be scoped, because I really felt there was something significant going on in the intestinal system. So I referred him to Dr. Krigsman. And eventually, they made their way to Krigsman. Krigsman scoped and found out he had abundant inflammatory lesions throughout the bowel. And these are just a few pictures here that are very similar to what I had shown you before. Inflammatory lesions indicating inflammatory bowel disease. And they initiated treatment very similar to what would be done for Crohn's disease, using some localized steroid and anti-inflammatory medication to try to turn down the inflammation. So what was the current status, or I guess what you could say, what is the current status through all of that, is that the violent outburst became almost non-existent, still with anxiety but manageable. Digestion, after putting him on medications for inflammatory bowel, really started to firm up for the first time in years. He's an individual who still needs behavioral intervention, but the severity of those behavioral problems were significantly reduced. And like a lot of families, they're still kind of in a fight with the insurance companies for ongoing medical treatment. That's a story that seems to play out very similar, across families across the U.S. And unfortunately, I think will just get worse. But for the most part, the situation appears stable. You never know with a boy with this level of severity. But what it really points to is the fact that of all the things that were going on, the inflamed bowel was a major culprit for his behavioral problems. He's still autistic, but the behavioral issues were significantly improved. All right, so let's talk about GI pathogens. And specifically, can GI pathogens negatively influence behavior? Certainly know that physical problems can, but what about gut bugs? Well, I'm not going to go real in-depth for this group tonight with respects to chronic candida, because I've done a lot of presentations on that in the past. There's certainly a lot of past webinars that you can listen to on that. But we do, as an introductory point, need to talk about candida, because it is a reality and it is a gut bug. So this is a study that was done in 2000 that highlighted that individuals on the autism spectrum, this particular study was looking at over 211 organic acid tests of kids, autistic males between 2 and 13 years of age, showed a much higher level of arabinose. Arabinose is the chemical specific for candida, compared to neurotypical kids of the same age and even less in age. So it's clear that the autistic kids, at least in this study, had much higher levels of arabinose, indicating chronic yeast. And we've known clinically for years that treating for yeast can make a significant difference in behaviors. And this was just a graphic representation out of Discover magazine that was relating a child's handwriting before antifungals and a month later. And you could see the keeping the letters within the line. It's much more legible. Again, showing that there is a brain effect that can occur when candida levels are high. So if you do the organic acids test from Great Plains Lab, you'll see the antifungal section on the first page. And one of the first places that my eyes are always drawn to is the arabinose, because the arabinose is very specific for candida. There are a number of other markers that sometimes show up, but the arabinose is the one that is most commonly present. And so if we list, sort of the common clinical observations seen in autism that at least appear in part related to candida overgrowth, kids many times have sugar and carbohydrate cravings that can intensify. The reality is that most kids like sugar, so we can't always say it's yeast, but that does seem to fit. There seems to, many kids, when their yeast levels are high, have a lot of heightened sensory seeking behavior. I've seen emotional instability, anxiety go up when yeast is high. Strange behavior, seeking pressure, hanging upside down, a heightened seeking of masturbation has been associated. The thing that's almost really classic, though, is the silliness, the goofiness, the giddiness, the inappropriate laughter, kids appearing drunk, parents describing that their kids almost look like they're drunk, some parents describing an alcohol or a yeasty type smell on their breath, even in their poop in some occasions. That should all be suspicions that candida is a problem, and looking to do the organic acids test as a confirmation, I think, is important. And I'll tell you why I feel like the organic acid test is important, instead of just assuming that all problems are yeast related. Well, if we look at traditionally at treatment, there are some standard medications which actually work pretty good. One of the ones that I like to use a lot for candida when we can prescribe is nystatin. Nystatin comes as oral suspension, it comes as tablets, you can get it compounded as capsules. Nystatin is safe to take long term, it doesn't get absorbed into the body to any significant degree, into the bloodstream so it doesn't cause liver stress, and it can be pretty darn effective. And it's not 100% effective 100% of the time, but it can be a good thing to use. So nystatin is really sort of an entry point from a medication standpoint for yeast. Then you get more into the systemic antifungals. The most common one is diflucan. And these have not only a local effect in the gut, but also a systemic effect throughout the body. The thing about these medications is that they do get absorbed, and so there is the potential for liver stress in some individuals, although in my experience that's very rare. And I don't want to say liver damage, because I've seen a few cases where the liver enzymes slightly went up and then went back down and never came back up again when the medication was stopped. So, but it is, it is important to do some liver testing if you're going to be using something like diflucan for a long period of time. So I'm not going to go into too much depth here with respect to yeast treatments, because we could do an entire presentation on that. But I just want to kind of point out that, yeah, yeast can affect behaviors, and it is a big thing that we deal with. Well, if we sort of cross over from the yeast issue and talk about the bacterial problems, then we really start to see where gut infections can really affect neurochemistry. To back up this point was a research article that came out in 2000, and it was called The Short-Term Benefit from Oral Vancomycin Treatment of Regressive Onset Autism. And what they did is they took 11 kids who were defined as regressive autistic, and they had some entry points. These kids had to have been on a broad-spectrum antibiotic. That was then followed up with persistent diarrhea, and then these were kids that also then had a deterioration of previously acquired skills that were correlated with autistic features. What they noted was that there was a short-term improvement was noted using multiple pre- and post-therapy evaluations, and they were doing video scoring of this as well. What they noticed was that there was improvement in about 8 of the 10 children studied. 1 child dropped out, but these gains were not largely maintained, and essentially what happened when the antibiotic was stopped, the kids regressed again. But the general comment was that these results indicate that a possible gut-brain connection warrants further investigation, and I would absolutely agree with that. If we take this a little bit further, there was an interesting article that came out in Cell, journal Cell, in December 2013, where they were taking a group of mice, what we'll call maternal immune activation mice, that were known to display autistic features, and that when their offspring were given, who also had issues, were given what was called a commensal bacteria, something called Bacteroides fragilis. This particular bacteria helps with improved gut permeability. What happened is that it essentially nullified, or at least diminished, some of the autistic behaviors. What they noticed in these offspring of these maternal immune activation mice is they had this abnormal profile in their serum of these different chemicals. And one particular chemical they found was something called 4-ethylphenyl sulfate. We'll come back to that here in a second. And so what they found, taking all this information together, was that these findings really support that the gut and the environment of the gut can affect the brain, and that this could be an area of intervention as an autism treatment. We'll come back to that in a second. These slides here are taken from a larger presentation by Dr. Shaw from Great Plains about the effects of Clostridium bacteria on gut health and mental health with respect to neurotransmitter imbalances. Well, there's been a lot of research coming out lately about the science of the gut and how the bacteria in the gut can affect mood and affect health. I mean, this is nothing that's really new to many of us who work in this field, and I'm sure to you as parents as well. In fact, they're even finding that the gut bacteria not only influence from a neurochemical standpoint what's going on in the brain, but it can also affect what's happening neuroanatomically. And when I say neuroanatomically, the main nerve that actually supplies information to the digestive system is a nerve that is directly connected to the brain called the vagus nerve. And we know that gut bacteria, like Clostridia, for example, tetanus, for example, can be transported up the vagal nerves and taken directly into the brain and affect brain function. So it's not just a neurochemical effect where you're getting a toxin from Clostridia or yeast that gets filtered into the bloodstream, filtered through the blood and makes its way to the brain. There can be a direct impact on the nervous system from bacteria in the gut too, being transported to the brain. And that's kind of what this particular study was talking about, is that certain strains of lactobacillus having an effect on GABA. GABA is that calming neurochemical in the brain, basically by influencing transmission through the vagus nerve. Well, if we take back and look at why the organic acids test is so useful, it goes back to the heart of chemical production in the gut from gut bacteria being absorbed into the bloodstream and then filtering through the bloodstream and up into the brain and nervous system. This was an article way back in 1956 in the Journal of Biological Chemistry, and what they found was that there was this compound called HPHPA that was found to be much higher in patients with mental illness, much higher than compared to individuals with just mental retardation. It was the mental health patients that tended to be showing a lot of this HPHPA chemical. In 2010, Dr. Shaw released an article in Nutritional Neuroscience that talked specifically about 3,3-hydroxy phenyl 3-hydroxy propanoic acid, or HPHPA, the same chemical that was being discussed back in 1956, and how it was being correlated with individuals with autism, and in one particular case with schizophrenia. This is a good article, by the way. You can find this off of Great Plains' website under the resource section. Well, what is HPHPA? Essentially, HPHPA is it's a phenol group. Okay, so we've got a phenol or a phenyl group. We've got this hydroxyl group attached to this ring structure. We've got the propanoic acid attached as well. And if you break this down and you look at neurochemically what can happen, biochemically in the body, we know that a lot of kids on the spectrum have phenol sensitivity issues. Their body either lacks or they've got some type of defect in the PST, the phenyl sulfotransferase enzyme, so they have a problem or a difficult time breaking down phenols. And we've got a direct compound being produced by a bacteria that part of it is a phenol. This is just from an article in 1995 that was showing comparison of an autistic individual's urine sample with a neurotypical individual. The neurotypical individual, I didn't put it in here, barely had any bands that were high, whereas the autistic individual had very high levels of a wide variety of chemicals showing up. This particular band here is linked specifically to HPHPA. Well, we know that HPHPA can be produced by Clostridium. The main thing today that is being discussed with respect to Clostridia is Clostridia difficile because of the severity that it can take with respect to an inflammatory bowel condition called pseudomembranous colitis. And this is just an image here of somebody with pseudomembranous colitis. But there are other forms of Clostridia that don't cause pseudomembranous colitis, but they can be problematic. This is just an image here of Clostridia under an electron microscopy. Clostridia species, there are many that can produce the HPHPA compound. Notice that C. difficile can do it. Botulism can do it, and a wide variety of others. And then there are certain Clostridia that are at least known not to produce HPHPA, but that doesn't mean that these guys are okay. Remember, Clostridia tetani is known not to produce HPHPA, but Clostridium tetani is quite neurotoxic. Why is this a problem? Well, it turns out that neurochemically, these chemicals can have an effect on dopamine. And dopamine is important with respects to mood and attention, motor movements in the body. But too much dopamine starts to infiltrate itself into the nervous system. And it particularly drives the sympathetic nervous system, or that fight or flight part of our nervous system. That can create a lot of problems. It can create problems in the digestive system, shutting down peristaltic activity, leading to constipation, poor digestion. It can increase heart rate, increase blood pressure, inhibit saliva production, just overall an increase of stress hormones in the body that lead to that fight or flight and anxiety issues. In this particular slide, I want you to take a look where we have Clostridia, multiple Clostridia species. What happens when there is Clostridia is it takes the amino acid phenylalanine and it converts it to HPHPA. HPHPA is known to inhibit a converting enzyme of dopamine called dopamine beta hydroxylase. Dopamine, through dopamine beta hydroxylase, is converted to norepinephrine. Norepinephrine is very important for attention and focusing. When we cause an inhibition of dopamine beta hydroxylase, we get a relative increase of dopamine, a spillover of HVA, and dopamine in excess can be neurotoxic. Also, Clostridia difficile can produce a compound called 4-creosol. 4-creosol is another chemical off the organic acids test that also inhibits this same enzyme, dopamine beta hydroxylase. Let's see if I can click over again. If we just looked at a couple situations with respects to HPHPA and autism, as the HPA, in this particular case, as the HPHPA level goes up, you see a corresponding increase of HVA or dopamine going up. But interestingly, we don't see the VMA, which is associated with norepinephrine, going up. The reason is the dopamine beta hydroxylase, which is the enzyme that converts HVA or dopamine to norepinephrine, is being blocked. Same kind of thing happening here. As the HPA goes up, the HVA goes up, and the VMA in some cases even goes down. And then that is, reversed many times when you treat the Clostridia. So HVA on the organic acids test, think dopamine. It's the major metabolite of dopamine. It's a major neurotransmitter in the brain, and it has often been found to be abnormally high in autistic individuals. VMA is linked to norepinephrine and epinephrine, and it's often found to be either low or low normal in conjunction with a high normal or high HVA. Okay, and so this particular study was just fairly similar to that other study that was looking at arabinose. In general, autistic individuals tend to have higher levels of HPA, showing higher levels of Clostridia than individuals of the same age who are neurotypical or younger. So why is dopamine in excess such a problem? And how does it correlate into the autistic condition? Well, dopamine is very reactive. Matter of fact, it is so reactive that it's easily degraded, and when degraded can create a lot of oxygen, or excuse me, a lot of oxidative reactive, what are called oxidative reactive species. Approximately more than 90% of dopamine is found in the terminal vesicles of dopamine neurons, and it's prevented from degradation. But about 10% is found just floating essentially in the cytoplasm, what's called the cytosolic compartment of the cell, and this is the major source of dopamine metabolism and presumed toxicity. Turns out that it's this cytosolic dopamine that undergoes degradation to HVA, and it's also the form that tends to drive oxidative reactions which deplete glutathione levels. So we know that glutathione is often depleted in autism. One of the reasons that could be occurring is because of excess dopamine. The other thing is that dopamine in excess not only overstimulates dopamine tracts, but the dopamine will infiltrate itself. It'll incorporate itself, basically taking the place of norepinephrine in the sympathetic nervous system. So it's a big problem to have it high. Well, Clostridia is a real difficult thing to get at in some cases. It's a strict anaerobe, doesn't like oxygen. Certain species of Clostridia, you've got the tetanus, you've got botulism, it can cause diarrhea. Most of the spores are highly resistant to heat, and even the spores are resistant to antibiotics. There can be upwards of 100 species of Clostridia in the digestive tract. It is controlled or can be treated with things like vancomycin, metronidazole, which is called Flagyl, and certain probiotics. There often, unfortunately, are recurrences after the use of Flagyl and vancomycin. Unfortunately, the spores are not killed by common disinfectants. As a matter of fact, there's some evidence that even alcohol hand wipes might actually spread the spores. Bleach is known to kill Clostridia, and there can be carriers. So there can be carriers who don't have symptoms that may also be spreading the spores as well. And then essentially, as you would expect, when you implement something like Flagyl or an antibiotic, you would generally see a drop in the HPA levels, and that's commonly what happens, but unfortunately sometimes things come back. So off the organic acids test, the HPA level often is seen with an increase of the HVA. Remember, HPA blocks dopamine beta hydroxylase, causing dopamine, which is the HVA level, to go up. In some cases, you will get VMA. That may be associated just with other stressors, but commonly you'll see HVA high, VMA low to low normal, in association with a high HP-HPA. And there's a lot of clinical usefulness of the organic acids test with respects to a wide variety of issues. So I don't want to make it sound like Clostridia is just specific for autism. It can be found in many other types of disorders as well. Let's get back to this discussion here about this, these maternal immune activation mice that were showing autistic characteristics, and the fact that when they did serum profiling, they found a wide variety of chemicals, particularly this one called 4-ethyl-phenyl sulfate. Okay? Well, what is 4-ethyl-phenyl sulfate? It turns out that 4-ethyl-phenyl sulfate, when they injected it into wild mice that did not have autism characteristics, they became autistic. And that this was actually found 46 times higher in autistic mice than not. Well, it turns out that 4-ethylphenyl sulfate is very similar in chemical structure to 4-creosol. 4-creosol is that compound that's produced by Clostridium difficile. Turns out I was reading that one of the things that Clostridium difficile does is it produces this compound to inhibit other bacteria so that it can thrive more effectively. The other downside to it is it too inhibits dopamine beta hydroxylase, and so therefore it's going to be something that also inhibits the conversion of dopamine to norepinephrine. And we have that same problem. 4-creosol and HP-HPA, basically coming from Clostridium bacteria, inhibit this converting enzyme, causing an increase of dopamine and the potential for dopamine toxicity. So when you think of a treatment consideration for individuals on the spectrum, the textbook sort of presentation for yeast behavior is, heightened sensory-seeking behavior, self-stimulatory behavior, sugar cravings intensified, kids becoming withdrawn, but it's that goofiness, giddiness, silliness, inappropriate laughter, which is really, really characteristic of yeast. You do sort of the flip side when it comes to Clostridia behavior, agitated, aggressive, biting, kicking, screaming. Difficulty is when you get both things going on, when you get a crossover of this, and that is a very common situation. So a textbook presentation doesn't always occur. And then there are various treatments for Clostridia. Again, these are really, this particular thing is just more focused on antibiotic treatment. Sometimes you can get rid of these things with natural remedies, but it's not always easy. Unfortunately, the antibiotics tend to work pretty well. What's interesting about, and some new information in what we're doing with respects to Clostridia bacteria, is because the antibiotics don't kill the spores of Clostridia, many times you have to do things in cycles. So I've had some success with Clostridia treatment where we treat for about 10 days, and then we cycle either flagyl or vancomycin on an every 72-hour basis where we do a treatment day for an additional 3 weeks. Now, the reality is that there is no one protocol that works 100% of the time for 100% of the people. There's even another protocol now that's being used where you're just for 3 weeks using an every other day antibiotic treatment. And that might prove effective as well. So sometimes you just kind of have to try some different things to see what works. But this definitely seems to work more effectively than just doing a straight 10 days, because what's happening is you're getting, as you're treating with the antibiotics, the spores are not sort of transforming themselves into an antibiotic-sensitive state. And then when you back off the antibiotics, the spores sort of transform themselves. You hit them again. You back off, you hit them again, you back off, you hit them again, and then essentially what you're doing is you're knocking the colony down to a manageable level where the rest of the immune system and the gut bacteria, the natural bacteria, and the digestive tract can take over. All right. So what are the reasons that I like to do the organic acids test and not just assume everything is yeast is because sometimes Clostridia is a problem too. This was a boy that had presented in my practice years ago, 5 years old at the first time of his visit. The diagnosis was autism. No pregnancy complications, a little colic as an infant, typical development up to about the age of 10 months. His parents did report he seemed to lack a need for physical contact, but other than that, there wasn't a huge concern. He breastfed for about 1 year, then he began cow dairy and solids around 6 months. Eye contact, again, appeared upwards of about 10 to 11 months, which then started to disappear. But he was still playful, and his parents described happy overall, and at that point was engaging with a sibling. Physical milestones appeared fine. Was babbling, but unfortunately never really got any word development, and that unfortunately never came. At about 15 months, parents notified the pediatrician their concerns regarding language. They were encouraged to kind of wait a little bit longer and see what happens. Medical history, multiple ear infections for the first 2 years of life. Matter of fact, the parents reported that it always seemed like he was on antibiotics for ear problems. Digestion, tended to have some hard stools during that first year, kind of transitioning into a second year. Periodically, parents would need to use some suppositories to kind of get them cleaned out. And then around 18 months, he developed an intestinal infection, had diarrhea and fever for about 3 days, given multiple doses of Tylenol to suppress the fever. No antibiotics were given because essentially they felt that it was just viral. The problem was within about 2 weeks after the onset of fever and diarrhea, he seemed to become more agitated and irritable, and also just didn't have a normal appetite. And this, progressed, upwards of about 20 months where he just seemed to disappear entirely. No expressive language, poor social interaction, not interested in sibling anymore, or even the neighbor kids. He easily became agitated, started side glancing, and particularly side glancing while standing very close to the TV screen. Hand flapping, finger twisting became his main fixation. So they went to the pediatrician. Pediatrician said, I don't know what's going on. Let's go to the neurologist. Went to the neurologist. Neurologist performed a Fragile X test. It was normal. Stated, nothing else I can do. He's autistic. Go to the regional center, get some, speech therapy, behavioral therapy, and that's it. So like many parents, luckily they didn't stop there. They started doing their own research, and they stumbled across information on dietary intervention, etc. And they implemented a casein-free diet, and that seemed to show some improvement in his eye contact. He began to sleep through the night, and this occurred very quickly within about 2 weeks, which is something I see quite a bit. You get a quick, many times, improvement with dietary intervention. Didn't see much with the gluten-free diet. They did some probiotics. His stools tend to get a little bit better, seemed a little bit happier. They started a multivitamin. It made him hyper, so they stopped it. That's pretty typical when kids got a lot of gut bugs. You put them on multivitamins, and sometimes it can just turn up the hyperactivity a bit for them. But overall, for the next year, things seem to stabilize somewhat regarding his autistic characteristics and his physical health. At about age 4, he developed an upper respiratory infection. He was given some antibiotics for it. Within the week of completing the treatment, he became unusually agitated and aggressive. He was hitting, screaming, scratching, and biting, just was not consolable. And this went on and off for about 2 weeks, but in reality never fully went away. So the parents thought, okay, this kid's got probably yeast, could be bacteria, let's just do some herbal treatment, grapefruit seed extract, some caprylic acid, could be all useful things. It helped with his eye contact, and it did lessen his aggressive behavior. So I came on the scene, and I suspected that he had probably some type of digestive bacterial problem that was contributing to his behavioral issues. And what I've seen over the years is that if you assume it's just yeast, if you've got Clostridia present, many times just suppressing yeast, you there's a weird relationship, I don't know if it's a relationship, but there's this competitive inhibition effect that seems to occur in the digestive tract. At least I've seen it clinically. And that if you just treat yeast and Clostridia is present, sometimes that Clostridia can come to the forefront. Came back, his organic acid test showed a very high HPA level of over 700 and an HbA level of 15, which we knew was causing a significant inhibition of this dopamine-converting enzyme, dopamine beta hydroxylase. So at that time, I didn't know about the cyclical dosing, but I treated him for 10 days with Flagyl. And like I always do, when we use an antibiotic, I'll put a child on some antifungals too, in this case, nystatin. And then we followed that up with some Culturel, which is a particular probiotic, to deal with the Clostridia long term. And it turned out that 5 days into his Flagyl treatment, the aggression and the irritability disappeared, completely. Within 3 weeks, he was happy, content, playful. Parents continued with the GFCF diet and probiotics. Overall, his gains in cognitive development and behavioral just kept progressing from then. I requested a repeat organic acid test to confirm, but in some cases, this is what happens. Lost to follow-up, they never came back. So I don't know exactly if he ever regressed again, if the Clostridia came back, or what happened. But at least in the short term, and for a number of months after the Flagyl treatment, he was doing extremely well. Okay, so I hope that was useful information for you. I know it's kind of a long lecture. And what I want to point out is there are a number of resources online that I have. Many of these cases are taken from a book that I wrote a few years back called Autism, the Road to Recovery. And you can find that at autismrecoverybook.com. That talks about kind of my philosophy and my approach to biomedical intervention. It's certainly a good introductory book. And then if you're a parent who maybe you're working with a doc, maybe you're not, trying to do things on your own, you have questions, troubleshoot issues, hey, I need somebody to kind of, what do they think about this supplement, or just need somebody else to bounce something off of. I have a website called autismactionplan.com where you can post questions. There's a parent forum. There's even a section for private messaging that you can reach me. I answer questions on this on a daily basis and on the weekends too. And if you're a practitioner as well, this is open for you as well. You can contact me through autismactionplan.com if you're working with patients and you just need some additional assistance or some suggestions, whatever it may be. Also, we have a website called Lab Test Plus, and this is labtestplus.com. And what we do is provide access to a lot of these integrative medicine tests, urine, stool, finger prick blood tests, and hair analysis. And the organic acids test through Great Plains is available through here. What you also get is a written interpretation based on the results. So you not only get the test results, which have sometimes their own interpretation, but not always, but you'll get an additional written report but based on what those test results mean, as well as some action steps that can be taken based on what the markers are indicating. Also, the other thing with respects to Lab Test Plus is if you have a question about, I'm not sure what lab to do, here's my situation or my child's situation, and I'm confused about what tests they are, you can post those questions to Lab Test Plus, and you just go into the which test section and submit your question. And I'd be happy to give you my feedback and suggestions based on my experience. Again, if you came on late, I'm going to be doing 3 different or 3 one-day intensive seminars. These are for practitioners. So if you're an MD, a DO, a naturopath, chiropractor, health, nutritionist, etc. The first one is going to be October 4th in Seattle, December 6th in Houston, Texas, and February 21st in 2015 in San Diego. You can learn more about those at GreatPlainsLaboratory.com. And of course, if you're interested in any private consultations with me, my phone number is right there at 951-461-4800. Email is info@mysunrisecenter.com. And I do phone health consults, Skype health consults, and then we do have certainly options for in-person consultations as well. If you happen to post some questions tonight, those questions will be forwarded to me. Usually you get them within the week, and I'll answer those on email. So I hope this was useful information for you tonight and that you found it valuable. And we will see you again next time for another webinar. Thanks so much.